Good afternoon, everyone, and a very warm welcome to the launch of DataBridge360 degrees. We're so pleased to have you joining us today to officially launch this tool that we've developed and we're very excited to share about. To open today's session, I'd like to welcome Professor Salome Masumi, our CEO, to just start the event for us on this important occasion. Over to you, Prof.
Thank you so much. Great pleasure being here. Really excited to be part of this, and also huge congratulations to the team, to you and the team for organizing this, and more especially for launching DataBridge 360. I'd like to extend a warm welcome to all of our colleagues from the National Department of Health, the South African Medical Research Council, our partners from academia, civil society, multilateral organizations that are joining us, such as UNICEF, as well as the universities that are joining us, University of Free State, University of KZN as well. And a special thank you to all of our esteemed panelists who will be part of today's conversation. They'll be introduced shortly, and you'll get to know them in a few minutes. Today's launch is very special to us as an organization. It's not just about launching a new digital platform, but it's about changing the way that we interact with health information, making it transparent, inclusive, and actionable. It brings this interface and bridge between the public, between the decision makers, and all of us that are involved in the healthcare cascade. And so huge congratulations to the team for this timely project and database that you've created. As HST, we are committed to strengthening the health system through evidence-informed solutions. And so the development of DataBridge 360 is rooted in our belief that data must serve the people, whether you're talking to policymakers, researchers, healthcare workers, or community. The platform itself bridges the divide between researchers, policymakers, the community, through the provision of matrix and indicators on a data-driven dashboard with resources such as educational material, multimedia videos, policy documents, tools for fact-checking, and community insights, putting them all in one place. So this platform will allow us to speak from a place of evidence, which is especially important for us, especially as we've really seen our role as being knowledge brokers for South Africa and contributing to public health intelligence for the country. This provides a common language for us with government, academia, civil society, and community, as I've mentioned. And so I'd like to congratulate once again the Research and Implementation Unit for this excellent work, building on years of providing very important products and tools for the South African health system. We look forward to seeing how this will be used towards strengthening HIV and TB response going further. And so at this point, it's my utmost pleasure to introduce our first speaker, Ms. Thulile Zondi, who's from the National Department of Health. She's the Chief Director for Health Information, Epidemiology, Research, Monitoring, and Evaluation. And so always a great pleasure to be with you. And I invite you to speak at this stage. Thank you so much.
Thank you, Prof. Masumi, and good afternoon to everyone who's participating in this DataBridge launch. We are very excited ourselves to be part of this initiative. Let me also acknowledge the presence of colleagues and other partners that are on the call and the panelists that has been mentioned. And also just to thank HST again for leading the way in terms of us getting to this point. And thank you, Prof. Masumi, and your leadership in doing so. And I think for me, really, representing the National Department of Health, it is quite a big contribution for us in terms of thinking about the whole evidence monitoring and evaluation landscape. I'm saying that because it's actually, I mean, this very space of how do we make evidence user-friendly, be packaged properly for utilization. It's one of the reasons why I actually got into the monitoring and evaluation space when it became fashionable a few years ago. But I mean, it really was that element of, hang on, there's research that I was taught, and then there's implementation on the other hand. But we do need to bring these two together. And also commend HSC because this is an initiative that is very much complementary to the work we are doing and also the one that we are developing, such as we are busy developing the integrated disease surveillance and response system, which will help us to deal with pandemics similar to COVID. So we are expected to be pandemically prepared. So this is one of the very, very good components. And you will recall that during the COVID-19, the issue of misinformation became very, very, very apparent. It became the number one challenge as we're trying to increase our coverage for the vaccine. And you see what is floating. So I'm very excited that we have actually gotten to this point where we can actually look critically at how the evidence is being managed. I think, I mean, in talking about data and health sector performance, you'll agree with me that we have actually come a long way. When we started, not even when we started, but I mean, at some point when in the early 2000s, when we were busy with primary health care and district health development, you got the impression that, the loudest manager had this invisible power. But over the years, we've built so many systems actually to make sure that the data is collected and also we facilitate the use. However, what is important at this stage is the fact that we need to make sure that we can package it better for use at systems level, but also the great challenge recently that we've seen with our communities. And just to be able to say that, to also be able to recognize the fact that, one thing I learned over the time is that managers or people are generally very busy, but they want something that they can look at, it makes sense, and they can be able to utilize. And I think we cannot possibly miss that opportunity. And amongst my key lessons in my career was when we worked with UNFPA and we funded the program for postgrad for demographers. Those are highly skilled people when it comes to data. However, when the program was evaluated, we were told that those people, when they get to service delivery, they are underutilized. And for us, the main lesson really was the fact that we need to work with the thinking both from the supply side, where we're talking to the supply of skills, but also the demand. So half the time as an expert or the leader in this area, you'll find that the managers might not even be aware of what is expected. And you translate that down to the communities. We have to do the pre-thinking in terms of what really needs to go out there and very, very fast. So it's an important initiative for us to be part of. And I think one important opportunity that we have with initiative like DataBridge is that we need to actually work with more partners to help us reach out the community. So I mentioned the community surveillance and also us building a system, but we need to work in collaboration with partners in order for us to be able to build this data in a way that is palatable. We also need to emphasize the issues related to data literacy or digital literacy. You know, the one thing that we can learn from the banking sector and the like, not even the banking sector, let me say just the cell phone, is that we all have learned to use our cell phone, even though they advance and whatnot. It wasn't difficult, but we see a lot in health where people really struggle to interpret our data, even the ones that we work with. So you can imagine the public. So we are really excited that HST has actually taken this initiative to lead us on this. So in a way, I think I would like us, as I close, to actually look closely at all the different data sets that we're busy with. And we need to ask ourselves the question of whether it is accessible, it is, can it be made friendlier or user-friendly for usability? And I think it's a big challenge because, I mean, we have gone past the days of us just collecting the data, doing the minimal with it. But at this stage, really, in the world where it's full of so much information, we do need to make sure that this data can be accessed as fast as we can. In closing, let me once more thank HST for leading the way and facilitating this launch. We look forward to more of these and advances of this platform in the future. Thank you, Chair.
Thank you so much, Fizondi, for officially opening our launch for us. And just thank you for your valuable insights in terms of your perspectives as a policymaker, as you're one of the key stakeholders for our platform. So to get us started, I'd like to also hand over to now Ms. Domfuti Blose, who's going to be showing us a quick video that's going to explain what our platform is about. Dombi was the project manager for this work, and she was also leading the development. And she's a data scientist here at HST. Dombi, over to you.
Thank you, Nolu. I'm just trying to share. Okay, so for some reason it's not sharing. Nolu, can you please try sharing from your side because it's not sharing on mine?
Yeah, let me see if I can do that.
South Africa's dedicated platform for tackling health misinformation using the power of credible data and community insight. Created by the Health Systems Trust, this platform helps you separate fact from fiction and make confident, informed decisions. Whether you're a health worker, policymaker, or simply curious, DataBridge360 is for you. Free, online, and always up to date with the evolving landscape around HIV, TB, and more. Here's what you'll find. The dashboard tracks search trends and health indicators using real-time data like Google Trends. The trackers show progress on HIV, TB, STIs, and co-infections, all in one place with easy-to-read infographics. Community Insights reveals what people are really saying, with real-time social sentiment mapped to key health issues. Click, compare, filter, even download insights to use in your own reports or presentations. If you need trustworthy information, the Resources section brings it all together in 5 easy-to-navigate categories. Educational, toolkits and guides that deepen understanding. Multimedia, videos and visuals designed for sharing. Policy documents, authoritative references and national frameworks. Conferences, a curated list of upcoming health events, with links to official pages. Fact-checking, explore localized, evidence-based responses to common myths. From daily decisions to strategic planning, these resources help you cut through the noise and act on what's real. By combining search behavior, lived experience, and verified data, DataBridge360 empowers decision makers. Plan better interventions. Target support. Track real-world impact. This is data democracy in action, putting the power of insight into the hands of the public. DataBridge360 is more than just a website, it's your window into the public health conversation. Discover the stories data can tell. Help build a better informed South Africa.
Hi, Ntombi, can you share your presentation or would you like to just speak through it?
I'm going to try again and see what happens.
Okay.
Thanks. It doesn't seem to be working, Nolu. But it's the same copy that you had. Do you mind sharing on your side while I speak to it in the meantime?
Sure.
Thank you. Apologies, everyone, for the technicalities. But thanks again, Nolu, for the introduction. Like Nolu has said, my name is Ntombi Blose. I'm the project manager for the DataBridge360. So you would have seen a 2-minute video, and this was basically a small video of what the platform is about, what it was meant to do, and what we had set out to achieve. Nolo will be sharing. I'm having some issues on my side. I'm unable to share. But basically, today's presentation is titled From Fragments to Flow, Introduction to DataBridge360. And the purpose of this video is to highlight the issue we had set out to solve, also outline how we design and build the platform, who it's intended for, and what makes it unique in the South African data landscape. Thank you, Nolo. Second slide. So I just want to highlight what really sets us apart as a platform. So DataBridge360 provides a full circle data ecosystem that integrates epidemiological, behavioral, and social data in real time. It also amplifies the public voice through data, where we merge community insights with official statistics. It provides progress tracking using an intuitive dashboard, which helps track local and national HIV/TB goals. It has no barriers, meaning the platform is completely open access. It has no login or subscriptions that are required. It also has a multi-sectoral design, meaning it's built for everyone, including policymakers, implementers, researchers, and communities alike. Next slide, Nolo. So why did we build this bridge? So the reasons are twofold. So the first one is around knowledge utilization. So as you would know, South Africa has invested heavily in the South African TB response, yet one persistent challenge remains: the widespread dissemination of misinformation. So in our highly connected digital world, social media and online platforms have amplified both information and misinformation at scale. This has contributed to confusion and mistrust among the public, weakening the impact of health messaging. To truly strengthen our HIV and TB efforts, we need a solution that could cut through the noise, promote credible voices, make accurate health data both visible and trustworthy. Next slide, please. The second reason is around a data ecosystem. Our health data landscape is itself fragmented. Despite growing investments in digital health, data relevant to HIV and TB is often trapped in isolated systems, inaccessible, inconsistent, or unintegrated. So we built DataBridge360, which is a response to this critical moment in our digital health journey. It was born out of necessity to unify these data silos, connecting digital tools to meaningful insights and transform disconnected data into coordinated action. Next slide, please. At the heart of DataBridge360 is a simple but powerful vision: to empower people through accessible, credible, and actionable information. Our aim was to build a platform that would make data usable and relatable to anyone. Next slide, Nolu. From policymakers to communities, improve health literacy and enable informed decision-making, and ultimately reduce the burden of disease by reducing misinformation. Next slide, please. To achieve this vision, we followed a structured and multi-phase design process. We first engaged stakeholders to understand what they truly needed. We identified target audiences and refined the product framework accordingly. We then developed the platform and piloted it using selected users. We then raised awareness about the platform. We incorporated feedback to enhance usability. And each step helped shape the platform that's not only technically functional, but also truly user-centered. Next slide, please. As a first step, we mapped stakeholders, and this was a very early critical step. So we knew that the platform had to serve multiple users, from health sector, media, researchers, and the public. However, ranking the influence and impact proved difficult. Each group brought valuable perspective, reinforcing our need for an inclusive and responsive design. Our next step was to assess needs more concretely. We conducted key informant interviews and a broader survey to understand users' expectations. Some of the key findings included over half of respondents wanted customizable search and filter features, especially separating HIV and TB content. 88% emphasized that misinformation largely stems from platforms such as X and Facebook. The preferred formats were dashboards and text summaries, and a striking 80% said they'll recommend such a platform. However, we noted some gaps, especially with regards to low representation from NGOs and civil society. This we aim to address in later phases. We then convened a one-day technical design workshop with key players such as our platform developers, a representative from the national labs, HST, and NDOH. Although the workshop provided valuable input, we faced a major time limitation where we were unable to establish the features, the target audience, and the content of the platform. Nonetheless, the session helped us refine a key principle, which was that the platform is not only a myth-busting tool, but rather a credible data source that helps user identify the truth through clarity, credible, and connection. Now we had our framework in place. Next slide, please. Thank you. With our framework in place, we turned to identify the content we needed. To do this, we conducted 2 rapid scoping reviews, which aimed to identify and map existing literature on misinformation related to treatment prevention uptake, adherence, and sources of misinformation in HIV and TB care. These insights inform the tone, focus, and keywords that now shape our platform's content and search functionalities. We also saw stories from real people and communities, lived experiences that bring data to life. By grounding our platform in real-world narratives, we aim to humanize public health data, making it more relatable and relevant. Other sources that we sourced for information are included on the slide. With regards to content creation, as of today, we have 21 pieces of content in production. We have a 3D storytelling video, which will be used to promote the platform use. We have 10 infographics, 5 snippets, and 5 text summaries, which will be disseminated on social media shortly after the launch. And these will be translated into other South African languages. These sources are designed to meet people where they are visually, linguistically, and contextually. Now that the bridge has been built, we now need you to walk across it. We invite you to engage, explore the platform, and share your thoughts. Please reach out to us with feedback. Your insight will help us improve and adapt. Thank you.
Thank you so much, Ndombi. As you can see, quite a lot of work and intention went into building this platform. And as she mentioned, we really do welcome your feedback and your insights, because we really feel like this is just the beginning, and we're going to grow this platform even more with your feedback and your content as well, and your inputs. So to start us off, I'd really like to welcome our diverse panel. They come from the public sector, also including academics and tech space, to community engagement and media oversight. Each of them will be offering a unique insight on how we can use information not only to inform, but also to empower people. I'd like to welcome our panel, and to start us off, please, can we welcome Dr. Velile Ngidi. Dr. Ngidi, please, can you switch on your camera so we can see you? we really want to turn to you as someone who was really on the front lines of the public health response during COVID. And in your role, while you were steering RCCE and the vaccine rollouts in KwaZulu-Natal, please can you just share with us how real-time data made things possible that possibly would not have been able to have been done if you didn't have those insights? How did it really change your response in service delivery?
No, thank you so much, Noltando, and good afternoon, colleagues. It's a pleasure to be part of this panel in a discussion that is so important. I think there's never been a time more than when we were responding to the largest crisis that we've confronted in our lifetime within our healthcare system during COVID-19 pandemic. So I think if we had to look at the value of data at the time, particularly as we evolved from actual COVID responding to the disease burden, number of cases, and we transitioned into the vaccination program, what we realized is that there were so many challenges when it came to us understanding, the risk profile of communities before the vaccination program. So we got to understand the kind of people that were at risk, where the infections were occurring, the understanding which communities had access to clean running water to be able to practice the infection and prevention control measures that we were requesting them to practice. So understanding that we needed information around in communities who's got access to cell phones, who's got access to transport. So we needed to access sources of information where we would have this kind of data to inform our response. So fortunately, we had plenty, although they didn't exist in a database per se or in a dashboard, but we were able to access data from just normal census by SSA. So we got to understand where to focus our response. We knew which communities didn't have access to water. So which communities we needed to structure our communication so that we are empowering them with, how to put together a tippy tap, how to do hand washing. Communities without access to internet, communities without access to cell phones. How are we communicating risk from community-based teams to local radio stations? But that we can only really focus a response if we knew who was at risk, where they were, to be able to focus and adapt our response. But then we also evolved to the vaccination program. I think we all knew, we started out understanding, okay, these are the age groups that we were targeting. And so as such, we started with the older populations. We needed to understand where they were, how many were they. And as we were vaccinating them, fortunately, we had EVDS, the electronic vaccination data system that was recording all the persons that we were vaccinating. But we needed to visualize that information so that we can understand, based on the numbers that we're targeting, who we were reaching and who we were not reaching. But those data boards actually evolved to a point where we even had geospatial mapping around, in a geographic setting. We were able to visualize in a specific ward by age profile who was being reached and who was not coming, in which areas were we having the biggest challenges. By making this information available to managers on the ground, they were able to say, okay, we need to focus community initiatives in these areas. We send out teams, social listening activities to understand what are the barriers to access to vaccines and respond. And I think we can all understand how acute that need was. That actually determined how successful our response was. But what I found most interesting, I think, when we talk about, when we sit in a platform like this and we celebrate a dashboard of this nature, a lot of us assume that all the managers that need this information, for an example, within a health system, will be able to access it. But we actually learned during COVID, especially the vaccination program, that when you've got a nice dashboard, you need a computer, and then you also need working internet to be able to access a live dashboard. But amazingly, quite a lot of our managers didn't have access to such. As such, we need to be very responsive in the way that we were actually making this information available. So that also saw us looking at how do we start printing versions of this dashboard at intervals that talk to how frequently information was changing and making this available, whether it's printed paper-based or shared via email as PDF, just to make sure that we're sharing those insights so they are continuously informed around how their change in response is actually effectively managing what we're needing to manage on the ground. So these were very valuable lessons that we learned as we were navigating a space of making information available, but also understanding that a health system is not just our managers and health facilities, but it goes into communities. You'd also remember there were so many other innovative ways that we were making information available in the hands of people that needed it. This included the Find My Jab app when we were trying to make sure that everyone who was looking for a vaccination site can go onto a website. They'll be geolocated where they are, and that platform will be able to tell them this is where your vaccination station is, nearest to your home. You can go and access vaccinations there. You remember the COVID Alert app as well when we're looking at actual infection and exposure to risk, because we would be exposed to individuals who might not know that they were infected. But we saw amazing developments during COVID, which I don't think we've had time to really digest how much we've learned during COVID and how much of that we can still take forward to really strengthen how we use data in the hands of the people that need it so that they can make best decisions around their health. Thank you so much, Dr. Tan and colleagues and everyone.
No, thank you so much, Dr. Ngidi, for your insights. And building on that theme of timely, actionable data, we're really now in an era where AI tools can track and even predict misinformation trends. Dr. Combring, please can you join us in just sharing how an emerging AI-driven infodemiology tools can actually be used responsibly in platforms such as DataBridge360 to spot and preempt the next wave of misinformation before it actually trends?
Thank you so much. And that's such a valuable question. I just want to point out to everyone that a system is only as good as the pilot that uses it. If you have an AI-driven system that has all of the level of sophistication in it, but the person using the system does not have the skills and competencies to interpret the information, then the system is quite useless. One thing that's really powerful about DataBridge360 is that it is designed in a way that is digestible and palatable. Now, AI-driven solutions are really just words we use for systems and mechanisms that automate processes to make the information we receive digestible. At the heart of this problem, what we're trying to fight and combat is both uncertainty. So if we don't know how something works, some people tend to, in an information void, unfortunately become very quickly misinformed. On the other hand, if you have social norms, so these are the norms that people believe within themselves to be true, and you have no evidence countering those norms or no single source of the truth, it also becomes a problem because it reinforces stereotypes and bias. AI-driven technologies can do that and potentially cause harm, especially if you think about platforms like X, where there's a lot of bot activity and people communicating using artificial intelligence-based responses. It's also the question of evidence. As we move into the future, there's a lot more synthetic data being generated. So we have deep fake videos that seem real, but they're actually not, to perpetuate misinformation and to a later extent, disinformation. But I'm not going to talk about disinformation at this point in time. One of the most important things, colleagues and members of the public, that we really need to internalize, grapple with, and understand is that if we don't know how to use these platforms and specifically interpret the information that is presented on the platforms, then we're not going to speak from an evidence-based perspective, and we're going to unfortunately perpetuate uncertainty. One of the greatest weapons we have in public health is communication. It's our means to communicate with the public. It's our means to communicate with our patients. It's our means to communicate and dismantle misinformation that could lead to public harm. So at the crux of it, AI-driven systems are the future. Integrating all of these platforms into a beautiful place, a dashboard with resources and evidence is the future. That's the way we should go. But if we don't know how to use them, interpret the information on these platforms, then it is useless. And so the call to action that we have for everyone is it's not just about DataBridge being a platform, here's the link. It's about us engaging with it, speaking with our systems trust, getting new data sources involved and evolving the system so that we as a sector can become better at responding to the patient's needs, better at responding to public health concerns, and ultimately mitigate all of the issues that come with misinformation. Thank you.
Thank you, Dr. Crumbring, for sharing that. I think we're all grappling with just the explosion or implosion of AI driven tools. But of course, combating misinformation is not just about data, it's also about the people who are consuming that information, especially young people who are both digital natives and influential voices. So, Mr. Koketso Tema, please can you share your insights in working with young people and grassroots sort of communities, and share your insights. How do we make this data and information relatable and co-create data stories with young people so that they can also become agents of truth in their own communities? Koketso, are you still there? Okay, I think in the interest. Oh, okay.
My apologies
Are you
for
there?
that.
Thanks.
My network was just giving me problems. I don't know if you guys can see me. If I'm visible, right? Thank you
Yes,
very much.
thank you.
Okay. Thank you so much. I'll just try and fix my camera properly. So you guys can see me. I do apologize for the technicalities, but thank you so much for the platform. I think with young people, they're quite important, particularly in the context of our organization. We're a volunteer-based organization, and evidently the largest volunteer movement in the country and in the world. We boast a volunteer base that is exceeding 20,000, where more than 50% of that base is young people. So the opinions and the work done is usually in the hands of young people. They have ownership of the data sets, and it's very important that they continue to have that. With that being said, with my experience, I think the most effective way is to create stories with these young people by centering the process around ownership, relevance, and ensuring that there's creative expression. Young people must not always be seen as passive recipients of this information or by the way or bystanders, but they must be active interpreters and narrators of these own realities. There's no better person to be able to tell the stories of their lived experience except for young people on the ground. As I mentioned, as the South African Red Cross, we saw this come to light through our peer education model. Fortunately, still being one of the few organizations that still adopt the peer education model, particularly in KwaZulu-Natal, which was affected by Mpox, if you remember. The Mpox outbreak in South Africa, it affected 3 provinces. It was Western Cape, KZN, and Gauteng, and KZN being one of, I think it was the second highest in South Africa. So what that meant is that we had to repurpose our youth peer educators because they were already talking about a disease that has a close proximity to HIV and AIDS. So with that being said, they go into the communities, particularly the schools, in particular secondary schools and places where young people gather, to be able to debunk these harmful myths that come with this disease. Thinking about that, Mpox in the South African context was a fairly new phenomenon. We had not seen it before. We had not dealt with it. There was no past data or past experiences with it directly. But however, we have dealt with outbreaks of this kind. Now looking at your COVID-19 that just passed a few years ago. So firstly, it's about localization. So using the most understood language. And we're not talking about just the language itself, as in the language of the language. We're talking about also the use of vernacular without moving away from the true data set or the true information, being able to use analogies, real life analogies, and using the use of visual aids where we're translating very sometimes non-digestible health data, which has so much jargon that needs to be broken down so that these messages are more trusted. So these grassroots approaches, it also assists both with the shift in community behavior, but also individual behavior, and furthermore, building a culture of peer-to-peer education, peer-to-peer accountability, and also fostering advocacy. So giving back advocacy to the communities itself. So looking at it more broadly, you combine participatory training, which looks at your data literacy and also storytelling tools. So being able to leverage off what they're already using. One of the most popular apps in South Africa is TikTok. The use of community radios, podcasting, and also doing impromptu, we call it, theater or whatever, when you're in the streets trying to act out what is going on. So it enables young people to turn all this data that is sometimes not digestible, it is hectic to take in, into much more dynamic, culturally resonant narratives. So when you go and you unpack it as a local myth, and then you map out the misinformation that comes with it, then it also opens up for the co-designing of how these insights are then communicated. Then we saw a very powerful shift. So then they became frontline mythbusters, and then became trusted messengers in their own right, because they are young people. They're then seen or perceived to be those who have much more of the information in the right way, but finding the most dynamic way in which to translate that information. And we must be reminded that this process must be inclusive, it must be collaborative, it must also be continuous. So sustainability must be there, which is why we have platforms like DataBridge to ensure that continuity. So it must also look at involving spaces where co-learning could be intensified, and where that data can be demystified. So where we are not looking at data all the time as just pure myth, but also being able to strengthen local resilience amongst young people, amongst themselves, and then turn them into champions of evidence-based action, which is very important for young people. Young people want to be positioned in such a way they can take ownership of our program. Don't just give it to them and then baby feed them, but being able to give them a rod, and they can be able to fish out that information and be able to do the things that need to be done in order for that information to be translated properly. Thank you.
Thank you, Koketo, for your wonderful insights. Yeah, I think just how much creativity is required around engaging the public, and particularly the youth who have all these tools at their disposal and social media to access different types of information. This is something we also grappled with when we were building this platform, about how do we reach the communities? How do we be intentional about ensuring that it's user-friendly enough for the public, outside of policymakers, outside of researchers, to really engage with our platform. But staying with the power of public participation, Real 411 has shown how complaints from ordinary people can be turned into real-time alerts and misinformation. So, Mr. Bird, please join us and just explain to us and share with us what can we take from the model that you have built to help a platform like DataBridge360 become a similarly responsive platform to inform misinformation in relation to health.
Good afternoon, everyone, and thank you very much for having me at this really cool event, and congratulations to everyone for the hard work that I can see has been put into the DataBridge platform. It looks really cool, and I'm looking forward to using it and sharing it with our Real 411 reviewers. So Real 411, for those who aren't aware, is a public complaints platform. Oopsie, sorry, I managed to switch myself off. Where any member of the public can report something they consider to be mis or disinformation, but also hate speech or incitement or harassment. So it deals with online harms. And then it gets reviewed by 3 people who then send it to a secretariat and the Secretariat issues an outcome. And depending on what that is, we can ask the platform to take it down or take other action. To give you a recent example, we saw some people of Operation Dudula were spreading some clear hate speech and incitement. We shared that with, it came into the platform in the morning. By lunchtime, it was shared with the South African Human Rights Commission, who were then able to alert the police, and they were then able to go to that particular community and make sure that people didn't get thrown out of their houses or weren't assaulted. So it's a way of seeing how you can, by taking action and empowering people to take action on a social media platform, they can actually reduce it. So one of the things that I think was really cool in participating in the RCCE over the COVID period was that we were able to track how misinformation spread as new trends emerged. So it became, you'll remember that when COVID first emerged, it was this thing of, no, there's no such thing as COVID, it doesn't exist. And then when it became overwhelmingly clear, it then came down to, no, well, there are ways that you can deal with COVID. If you stand upside down and drink hot water with garlic in it, if you do all of these sorts of things, and then some of the quack doctors coming out with some of their supposed mechanisms, and then as that developed, you saw it moving to the vaccine. So it's now stands as a public archive to allow people to see what and how misinformation spreads. So what I'm hoping is that we can establish a partnership with your platform, with DataBridge, and allow people to report things into it, because it's by taking action, even on a case-by-case basis, these things can have a real world difference. And we can hopefully encourage more people to be a little bit more cautious before they simply share whatever nonsense they find. But 1,000 congratulations to everyone.
Gosh, sorry, I hadn't unmuted myself. Thank you so much, Mr. Bird, for sharing those critical insights in terms of how we can really use the model from Real 411, which is such a great platform, to also feed into DataBridge360 in addressing misinformation. And technology, it really is always evolving, as we've already heard from some of our speakers today, but integration continues to remain a challenge, especially in health. So Dr. Benjamin, you've helped scale mHealth across the continent. In your view, what interoperability challenges exist and stand in the way of mobile health truly feeding into platforms like the one we are speaking about today? Please, could you join us?
Lovely. Thank you so much, Nolutando. And congratulations to HST for getting DataBridge together. I think it is really, really useful. And I like the name. There's lots of things around water in data streams and data lakes and oceans and seas, whatever, but you're getting over that, so you can go to the other side of all this water to do something useful. So really appreciate DataBridge360. Interoperability is the name given to a major barrier of getting different sorts of information to talk together. Think systems like DataBridge aren't just from one source of data, but as you're hearing, there are dozens, multiple, even hundreds of data streams that need to go into something like a large-scale health information system. And the problem is often the systems are from different organizations, different companies, different technologies, and they use the terms differently. For example, famously, the term pediatric, like for children, can have, some people said, up to 12 different definitions of what age pediatric goes to. And if you don't have all those things properly defined, the data you get from all the different sources is not very useful. It gets into junk quite easily. And famously, in digital health systems around the world, getting the tech working is hard, but is much easier than getting all the information coherent and working together. Luckily, South Africa has actually been quite good at this. There's something called the Health Normative Standards Framework that was developed over a decade ago in 2013 that says this is how the different information data sets should be able to work together. But that's lovely as a piece of paper, and some projects that work directly with government have done it, but many other systems haven't. And I'm talking particularly about some of the private sector systems, some separate systems funded by international agencies or donors. So there really was a major barrier, lots of different little puddles of information that didn't really connect together. So is it ever possible in a context as impressive but also confusing as South Africa to get all the different sets of data working together? Well, luckily, we know the answer to that, and the answer is yes, it is possible, because it did happen during COVID. With the huge political national attention on COVID, systems that often take months, even years to get properly working, just made things happen over weekends. The president asked the Minister of Health, the Minister of Health just got everyone in the room and said, do it. And within a week or two, for the first time, with public and private sector health information systems around patients in hospitals, the number of beds where some people went from the private sector to the public or the other way around. So it started to show that some forms of interoperability are possible, in particular, but when there's the political will, when there's the national drive, when people aren't saying, oh, I can do that in 6 months' time, or what do you pay me to do anything there? Also, you may remember EVDS, the electronic vaccine data system, which was set up very quickly and was linked to and used nationally. So again, these systems can work effectively, but only if there is basically the technical skills needed, but also getting everyone together. For time, moving on, if I can just end with a dream I've had and I discussed with several people on the platform. Can we think of a system like DataBridge360 in the future being of use to everyone in the country, not just people in NGOs and governments? So having information systems that genuinely seek to empower people to take care of their own health. So it's not just about getting people to link into the formal health system, which we know is overburdened, but can we move the health system to preventative, not just curative? So providing all the information people require to know what it means to take care of themselves and other people in their family. Ideally with a health check from a nurse or somewhere else in a clinic or anywhere else in their community, or if that's not possible, through online systems you go through. And then making your cell phone be a way of supporting yourself in your individual health journey. And there are various projects around the world that have done this, but and there's now a term, the digital determinants of health. How does the digital access, the cell phones or computers, link to people's health? I have a dream, in 3-4 years, can we have every cell phone, smartphone that is sold in the country have preloaded Department of Health app? And every day in newspapers, on TV, suggestions. This is how you link to know more about TB, to know more about HIV, about the whole range of health issues we have. And just with that, congratulations again to the HST and for building this DataBridge360, a very valuable tool. And we hope a step onto the next stage where the digital determinants of health can improve the health of people throughout the country. Thank you very much. Back to you, Nolutando.
Thank you so much, Dr. Benjamin. Gosh, yeah, you touched on so much, the digital determinants of health. Yeah, I love that term. And just finally, as we think about how data translates into impact, we must ask what data actually matters for changing behavior. Ms. Simon Mayer, please just share with us, based on your experience designing behavior change strategies, how do you distinguish between the noise and signal when crafting messaging, especially during emergencies?
Hi, thank you very much, and congratulations again, and thank you all the other speakers as well for your insights and provocative thoughts as well. I think the point is, perhaps I'll even go back to what Dr. Kumbrink was saying. How we decide what we respond to in all of the noise comes back to who's deciding and what are we looking for. So we need to, and everybody will be different. I mean, there are going to be many different users of this amazing platform, and each will have their own areas of interest. So before going and looking is the question of who's going to do the looking, who's going to do the data analysis, who's going to look at this from the program action side to kind of see what steps we can take in response. And thereafter, what is it that we're looking for? What are the specific things? And I think that's been a big learning with the absolute proliferation, the scale and the enormity, the flood of information means that it's really impossible to look if you don't be as specific as you can about what you're looking for. And that question needs also to help you figure out what actions you can take in response. So, you know, rather than be just a broad, well, what are people saying? It's what are they saying about something specific in a specific area at a specific time, and which people are we talking about? You know, that kind of research question that I think many are already familiar with. And then that really might help us identify signals that are important. But from there, what do we do? Again, it's speaking to you know, the pilot that was mentioned earlier, and also to what was said earlier in the introductions in terms of strengthening our system around infodemic and infodemic management, is to have some kind of data analysis plan. I mean, if we have a question and we know exactly what we're looking for, and there may be various questions people are using, for each one, you know, how are we going to analyze this? What are our indicators? What is going to tell us? And here's the thing, I think that speaks also to your question. What is the level of risk that this issue we are picking up poses to public health and really the objective we're trying to achieve? So we need to have some way of figuring what determines risk in this instance. You know, what is going to say this piece of information is a particularly risky one because it will impact on what people do or not, and what is low risk. So therefore, excuse me, we might not need to respond as much. So those kinds of, I would say, structures, but also a little bit of planning. In terms of identifying what's important, is you need to plan ahead. And also as we mature in how we do this, again, I mean, this is so much learning from COVID, going right back to Dr. Ngidi was saying earlier. I think we've all learned so much in the last 5 years. But ideally, we should be able to also validate across different data sources, you know, the noise. Is it really something we should be responding to, and who can tell us? And then if we say it's risky, if we understand that it is true, is it important enough for us to take action, and what is actually going on here? That's then how we formulate the responses that we need to take in tailoring our work to the noise that we're picking up, or the signals that we feel are important. And the very last point I'd like to say is it's not only about communication. So our actions are not only, we cannot just recommend to go and tell people more, or tell people more information about how vaccines are safe when they don't trust government in the first place, for example, or to tell people that services are free when they actually don't want to go anywhere near services because there are other issues around getting there that are a problem. So I think we need to be very, very clear in terms of our actions that we recommend, that we can't just imagine that messages are going to solve every problem. There really is a whole range of factors that influence on our objectives and our achievements. Thanks very much. Over.
Thank you so much, Janine. Yeah, Thank you for the rich insights to our panelists and just the thought-provoking contributions. I think what's clear from this conversation is that DataBridge is not just a repository of information, but a tool for change. So as we really continue working on developing this platform, please do connect with us and keep some of the takeaways that we've gotten from our panelists this afternoon in terms of how do we make this platform responsive and just better in terms of addressing the different people we really want to get this information. So please do just stay with us for a few more minutes as we close up the session. I'd like to just hand over to our director, Ms. Ashley Padarath, to just conclude the session for us. Thank you so much.
Thank you, Nolu, and good afternoon, colleagues. We've come to the end of what has truly been a rich, thought-provoking and inspiring discussion. One that has surfaced some critical issues, sparked some innovative thinking, I hope, and offered some ideas for how we might bring together information in a way that is coherent, accessible, and impactful. So as we close today's launch, I want to take a moment to reflect not just on what DataBridge360 is, but on why it matters and where we go from here. DataBridge 360 degrees is not just a dashboard. It's a bridge between evidence and impact. Conceived by HST with support from the South African Medical Research Council Grand Challenges Initiative, this is our collective response to a pressing challenge on how to cut through the noise and fragmentation and bring trusted data into the hands of those who need it most. We've seen, as Dr. Ngidi reminded us, that credible real-time data can result in real-world action and can save lives, as it did during the COVID-19 pandemic. We heard from Dr. Combrink and Mr. Bird about how AI-driven systems and social listening can illuminate and counter harmful narratives before they take root. Mr. Temba reminded us of the power of co-creation, of listening first, especially to young people, and building with, not for. Dr. Benjamin and Ms. Simon Mayer showed us that good systems alone aren't enough and that adoption and trust are just as essential. I think all of our imaginations have been captured by the phrase, the digital determinants of health, and I look forward to seeing how we can incorporate that into our future work. So colleagues, this is the spirit of DataBridge360. It is a living platform that brings together diverse sources of insight, verified and contextualized, and made usable for communities, practitioners, and decision makers alike. Ladies and gentlemen, I'd like to express our heartfelt thanks to Professor Maswime, Ms. Zondi, and our panel for their time and their expertise, to the South African Medical Research Council for believing in the potential of this work, to the HST team, particularly Ms. Ntombi Bloze and Noluthando Ndlovu, who led this work, as well as to our exceptional developers, WIMI, who brought this vision to life, to our users and partners who helped us test and refine the platform. Your feedback has been invaluable. And to our communications team and everyone working behind the scenes, thank you for making today possible. But this is just the beginning. As we expand DataBridge 360 degrees beyond HIV and TB, we invite you, our community of data stewards, storytellers, and change makers, to shape its future with us. So here's our call to action. Researchers and NGOs, please, let's break the silos. Share your validated data sets with us. To journalists and content creators, help us translate our data into compelling stories that rise above the noise and counter misinformation. Policymakers and program managers, we ask you to use this tool to anchor your strategies in evidence and lived experience. Because bridging data and decisions is not just a once-off launch. It's an ongoing commitment, one grounded in collaboration, trust, and accountability. Thank you to all of you who stayed with us online, even though we've exceeded our time. It's an ongoing commitment we have to ensure that DataBridge360 improves and incorporates other sources of information. Thank you for taking this first step with us today. We look forward to seeing you and your work on DataBridge360. Have a wonderful afternoon further. Thank you.
Thank you, everyone.